As you all know, first I want to introduce some more terminology, which I think everybody should know about it. Apart from the infertility, which everybody knows that it's inability to conceive after 1 year of unprotected intercourse, we have to know something called fecundity rate. So the fecundity rate is about 20 to 25% between the age of 20 to 30 years of age, and decrease to below 10 years, to 10% below the age of 35. So what is that meaning? If you have a patient today, she is 25 years old, and you start her fertility treatment, what is her chance to become pregnant without, now let us start with the normal patient who have no infertility issue, and she wants to conceive this month. What is her chance to become pregnant this month? It's only 20 to 25%. Okay, so it's not 100%. It's only 20 to 25%, and that is only if she is below the age of 35. After the age of 35, her chance to become pregnant spontaneously in that month is only 10%. Okay, so you have to put that in mind when you counsel patients. And then you have accumulated pregnancy rate, which is how much they become pregnant without treatment after 12 months is about 93%. So that's why infertility is considered to be a disability, okay? Because of these issues. And you have something which is there and it's disable. It's not 100%. It's only it's less, 20 to 25%, okay? So when we talk about ovulation induction, that is the meaning of it. It's a pharmacological treatment of women with an ovulation or illegal ovulation with the intention of inducing normal ovulatory cycle. So if you have a patient who is having an ovulatory cycles and you want to give her fertility treatment, we call that ovulation induction. Controlled ovarian stimulation is a woman which the ovaries are stimulated to ovulate more than one oocyte. Okay, so that's what we usually do. The first one, when we do in the fertility clinic, our aim is to produce monofollicular, maximum 3 follicles with the fertility treatment, not more than that for the patient who are having normal fertility management in the clinic, in the OBD. The aim for it maximum will be for IUI. But patients who are going for IVF, we need more than that, of course. Okay. So how we do that? These patients should go for ovulation induction or with IUI plus minus IUI or IVF mix. Usually, we have to look to the duration of infertility and the age of female pattern. For me, this is very important. And why is that? Because the probability of achieving a live birth without treatment decreases with the increasing age and duration of infertility. Pregnancy without treatment declined by 5% for each additional year. So if you have a patient today, she got married, and you have to decrease, you have to counsel her in a way that each year her fertility, her ability to conceive naturally is decreased by 5%. Okay? And that is, by 15 to 25% for each added year of infertility. So after that, it will decrease even further. And that's why we consider after 3 years, when I get a patient who is infertile for about 3 years, I don't go for ovulation induction alone. If she wants to conceive, I will go directly for IUI if there is a way to do. Otherwise, after 5 years, don't talk about even IUI. Go directly to IVF. Because anyway, even if that patient is 25 years old, we have a patient who is, don't consider only age, duration of infertility. Because what happened, the cause of infertility will not improve by waiting further, even if she is 25. For example, if your patient is having a tubal factor, it will not improve after 2 years or 3 years. She should go directly for IVF. You know, if the patient is they have a male factor or mild male factor, and you want to IUI, you go directly to IUI. Don't hesitate, just give her ovulation induction. There is no room for ovulation induction alone for patients who are ovulating naturally. There is, we have to put in mind also past medical history, surgical history, the social history, causes of infertility, as I said, past reproductive performance, previous medication use for ovulation induction, and number of previous cycles, and if they use IUI or not. So for those patients who are above the age of 35, don't wait, please, for 1 year. Please don't wait for 1 year. Enough 6 months. In fact, I sometimes ask them after 4 months to come. Okay, evaluate earlier than 1 year for patients with irregular and infrequent menses. It is, yeah, the causes is there. Why we need to wait for 1 year? Okay, wait for 1 year only for those who are having no issues, ovulatory regular cycles, history of pelvic infection, hydrosalpinx, endometriosis, as Dr. Naam says. Patients who are having previous oophorectomy for any reason. Okay, don't wait, please, for 1 year. History of extensive ovarian surgeries, whatever the cause, please don't wait for 1 year. Patients who are having previous chemotherapy and radiation, don't wait for 1 year. Smoking, because that is decrease their fertility preservation. Known to have, as I said, poor semen quality. The type of infertility, patients who are having tubal factor, male factor, then they better go for IVF. There is no need to wait further. Okay, it's the type of infertility when you evaluate them, which make you choose what type of management they should go. As I said, male factor, semen analysis are decreasing by time, and now we are in 2021, where almost, believe me, almost we are now coming to 70% of the patients coming to the fertility clinic, male factor. That is obvious. And there are many ovulation induction, the normal one. It is also, even with IVF, the success of becoming pregnant is decreased after the age of 35. So this you have to put in mind. That's why we want them to go for fertility treatment early, and even for IVF also early. Not only that, the birth rate decreased with women age, pregnancy and birth is even, as I said, with IVF. And even those who are using fresh embryos, that is decreased. This is similar almost. Pregnancy loss, also miscarriages increase with the age and with the ovarian reserve. And so the fertility and aging, they are not together. So you have to see your patient as a whole. Age can affect oocyte number, quality, luteal phase dysfunction because of the impaired in the ovulation, impaired fertilization rate, impaired implantation failure, poor quality embryos. They may go into endometrial respectivity will be less, high incidence of age-related issues come more with age, like fibroids, endometriosis, they become even worse by time. Decline in the sexuality, earlier implantation failure and clinical losses, increased incidence of general medical problems with the age, which can decrease their infertility further, high incidence of obstetric complication. So what is the most important ovarian reserve test? If you want to do the FSH, do it in the right time. And then interpret it, as Dr. Naam says, you have the good interpretation right. Although it is not the good marker to go by because of the fluctuation which happens during the period of menstruation. The one which we take is usually anti-Mullerian hormone and ultrasound for intrafollicular count. They have similar predictive values. Several studies say that the linear correlation between AMH and live birth rates is better even than the intrafollicular count. And the AMH appears more useful when counseling couple about the chance of live birth after the IVF. So there is no need to be done unless you are going to counsel them that they are going for IVF. But for those patients who have a good intrafollicular count on the ultrasound, there is no need to do anti-Mullerian hormone. Age is one of the most reliable indicators of ovarian response, but sometimes we do see women of similar age may have wide variation in the ovarian response. So the World Health Organization classification for anovulatory cycles divide them into hypogonadotrophic hypogonadism, and then those who are having normal gonadotrophic, normal levels of gonadotrophins, hypergonadotrophic hypogonadism, and patients who are having hyperprolactinemia. You know, I think already some sort of just examples. Let me go this, yeah, okay. So how we manage the anovulatory cycles in the clinic? Usually, if that patient is coming for you for the first time, we either use Clomid, letrozole, or gonadotrophins. It depends on their age, what the medication they used before, and then go on from there. We sometimes, when patients have resistance to Clomid, we may go to laparoscopic ovarian drilling, monitoring how we monitor, and the need for HCG, luteal phase support. And then finally, I will talk about the ovarian hyperstimulation syndrome. Clomid is the most commonly used medication. It's non-steroidal selective estrogen receptor modulator. There is not known to have any teratogenic of significance, no increased risk of ectopic pregnancy. Usually it's bind to the estrogen receptors, and the negative feedback will increase the FSH, so it will stimulate the ovulation. Usually we give the Clomid, start with the 50 milligram orally for 5 days, and usually better you start between day 2 to 5 of the menstrual cycle, with ovulation, of course, after, you bring those patients, if you start today, bring them after 5 days from the, or 10 days after the last dose. Usually I see how they did in the previous cycle, so I will ask them when to come to see that, to monitor them. According to the literature, their pregnancy outcome are similar wherever if you start the ovulation index at day 2 or 3 or 4 or 5, there is no difference. You can start in any days of the first 5 days of the period. The women, if they are unresponsive to 50 milligram, then you can double it. And those who have unresponsive, in a proper way with Clomid, usually if they have a good response, you can go up to 9 cycles. There is no need to do more than that, in fact. Even sometimes we stop from 6 cycles, because if the treatment does not work, it's not going to work unless you are going to add another medicine. Please don't go on giving Clomid. Clomid is well known to have some sort of ovarian epithelial tumors. Usually 75% of the patient will ovulate in less than 150 milligram. Patient who fail to respond to Clomid, if you want to give up to 250, which is rarely required, don't go even more than 100 to 150. If there is, because there are other options which you can give them for 6 cycles. And if they don't respond, stop that Clomid, please, and go to alternatives. 15% of the patient do have Clomid resistance, and the risk of multiple pregnancy usually with Clomid is around only 2 to 13%. Discomfort is very minimal, and the side effect is usually, which is very important, and that's why you have to measure the endometrial thickness when you give them the Clomid, because sometimes it affects badly the endometrium. It's becoming thin and it's not suitable for the implantation. And that's why sometimes you need to add estrogen during the while they are on Clomid in order to improve the endometrium. And also the cervical mucus can become thicker with the Clomid. So that's why Clomid is not an ideal in some of the patients, especially who are having mild male factors. There is something called a stair-step protocol. It's not being done usually much, but it is very easy. It's very easy and it's helpful sometimes, especially for those patients who cannot come again and again to the clinic. The ovulation did not occur after the 5 days. I mean, if you give them now 5 days of Clomid today, 50 milligrams, and you bring them after 10 days, and there is no endometrial response, no follicular response. That means the follicles are still below 12 or 14 mm. So you can immediately increase the dose. There is no need to give them to bleed and start again the next cycle, okay, the 100. This is a stair-step protocol, which is proven to be beneficial. Sometimes this is decrease the patient burden and coming again and again to the clinic. I mean, it's okay also to use, and it's okay if you want to bring them again. But this is well known, you can use it. There are many literatures which is how to use these stair-step protocols for ovulation induction. And there is no need to induce patient to get their period before starting Clomid. If you find there is no follicular cyst, or there is a thin endometrium, you can start immediately. There are some others which is now not used for the ovulation induction, like tamoxifen or loxifene. And then we have the other option is letrozole. It inhibits the conversion of androgens to estrogens. It just results in estrogen deficiency. And again, this will increase the FSH production from the pituitary gland. And it's a drug of choice for ovulation induction, especially with patients with polycystic ovarian syndrome. Usually, we start with 2.5 to 7.5 milligram per day, maximum dose of 7.5. We give it again similar to Clomid. And the adverse effect of which we see it with the Clomid, it does not happen with the letrozole. And there are reports of good pregnancy rate and lower incidence of multiple pregnancy. There are lots of talks regarding the fetal safety with the letrozole, but so many literature says this is a systemic review which was published in 2021, which really was a relief for so many who are using the letrozole for ovulation induction. There is no evidence that letrozole can increase the risk of congenital fetal malformation or pregnancy loss compared with Clomid or natural conception or other fertility agents. So it's very safe drug and very useful drug. Letrozole also been used for other reasons rather than ovulation induction, like intrauterine insemination. Sometimes we use it in IVF, fertility preservation, and preparation of endometrium for frozen embryo transfer. Then if we come to the gonadotrophins, we have human menopausal gonadotrophins, either mixed FSH with LH, or we have recombinant gonadotrophins. They are either IM or subcutaneous injection. Usually we start with the lower dose and we increase it gradually as how the response will be. And risk of multiple pregnancy can increase to 30% with the gonadotrophins. That's just protocols how to use them. There are laparoscopic ovarian drilling. It can be done in patients who are having clomiphene citrate resistance only if you don't have other option. Otherwise, there is no need to do ovarian drilling. Other options are available. You can add gonadotrophins. You can change to letrozole. You can give them letrozole. There is no need to do ovarian drilling nowadays because of many risk factors. There is admission, anesthesia, surgical risk, and so on. So this is not the option anymore nowadays. And it's increased also. It can affect even the ovarian reserve by doing so many punctures if you don't know how to do it. So usually how we monitor the ovulation induction, usually we use the ultrasound, and we expect the follicle to grow after 14 mm by, even if you see a follicle of 14 mm, that means your medication is working, and you expect after that the follicle to grow by 1.5 to 2 mm per day. Then you can now schedule where you will do her, even to give her CG if the weekend is coming, for example, and when you are going to ask her to come for an IUI. People are using basal body temperature, urinary LH kits, progesterone levels. We don't do much of this nowadays. We mainly go by the ultrasound. So is there an importance of follicular size before administration of HCG? Yes, there is an importance, because more you have bigger follicles, you have better fertilization rate. Take it in that way. For example, it's a 14 mm follicle, so the fertilization rate will be about 40 to 50% fertilization rate. More like 18 mm, then it's almost 80 to 90% fertilization rate. So bigger the follicle, better fertilization rate. So that's why your aim should be to increase the follicular size to more than 18 mm. Then if we come to the HCG usually we have two types, either the recombinant or urinary HCG, and the Cochrane database says that there is no difference between the two and you can use any of them, even with the risk of the OHS. Do we need HCG prior to the IUI or not? With the ovulation induction, as per this, the administration of the HCG, if you are going to do an IUI, yes, because it will improve. Take please that HCG is not wrong if you give it, but what we said, is it beneficial for those who are not going for an IUI? No. Anyway, they are going to ovulate because you are not suppressing their pituitary. So anyway, the LH is coming, and as the follicle is increased, the LH is coming, and she will ovulate. But to ensure that it's ovulation, we sometimes give. So for those patients who are not going for IUI, it's of no benefit. Only for the IUI, just to monitor and to decide when you are going to do an IUI. Of course, I think you had already a lecture about an IUI and how to do it and where to do it. I will skip that part. And then we come to the luteal phase support. Do we need a progesterone or Dhofar after giving the follicular clomid, letrozole, gonadotropins, and IUI? Again, if you are not suppressing or you are not super enhancing the ovaries, there is no need. Okay, for those patients who are having normal, regular cycles, there is no need. If you are giving clomid, there is no need. Okay, but if you are giving gonadotropins, you are planning for an IUI, maybe that would be of benefit. So that's why routine supplementation of luteal phase with vaginal progesterone does not seem to improve the pregnancy rate for patients who are going for clomiphene citrate for an IUI. But those patients who are going with the gonadotropins, it may help these patients if they are going for an IUI. So yes, again, if you are going for clomiphene, you are planning for an IUI, for those patients who are going with the gonadotropin, it may help them. Controlled ovarian stimulation, this we usually use it for the patients who are going for an IVF, and they are different. So many protocols, we modify them from one patient to other according to the patient characteristics. And of course, you have to put in mind that ovarian hyperstimulation syndrome is one of the risk factors you have to put in mind for patients who are going for fertility treatment using the fertility medications, usually with clomid. It's very, if it's there, it will be very simple and very mild. For the IVF, it's very high, and that's why we have Nowadays, we have so many things to improve the success and to prevent the ovarian hyperstimulation for those patients who are going for an IVF, like using, first we have to predict them who are going, so choose the proper protocols, and then to treat accordingly. Usually the OHS for most of the time for these patients, it's usually self-limiting and usually resolved within 7 to 10 days. But if the patient becomes pregnant, then it may increase and it may continue for a longer time. Most of the time, we treat these patients mild to moderate as an outpatient. We call them almost every 2 days, 72 hours sometimes, to come to the OPD. We treat them with an IV fluid, make sure that they are passing good amount of urine. We check their hematocrit, their hemoglobin, make sure that they are doing fine. We supplement them with sometimes heparin to make sure that there is the incidence of thromboembolism is not there. And so most of the patients now, we don't admit patient unless it is really severe OHS, or we know that these patients will not be able to come to the hospital for monitoring. And that is right if you do it, because there are so many literature says that the outpatient management, in fact, is better and effective rather than admitting these patients. And aggressive treatment, even sometimes even, prosthesis, removing some of the fluid from the abdomen can be done as an outpatient. Of course, it's increased, as I said, the OHS increases if your patient become pregnant, and there is sometimes even the risk of miscarriage with that. I think the prevention with the IVF, we usually do antagonist protocol. We trigger the ovulation with agonist instead of HCG. And we freeze all when we do the OPU instead of do fresh ET. We do frozen cycles. And we usually sometimes give them cabergoline, most of the cases. We give them for about 8 days. Even for those patients who are not in the IVF, but they have, we can give them cabergoline. Sometimes even we give them agonist. So what is the importance of individualization? Several protocols of the controlled ovarian stimulation studied in order to find the therapy which ensure the best outcome in terms of pregnancy and live birth, minimizing iatrogenic risk and the risk of cycle cancellation due to poor response and ovarian hyperstimulation syndrome. The concept of one size fits all for the ovulation induction is not there anymore, and you have to individualize. The ovarian response to stimulation should be based on knowledge, ovarian reserve, and the outcome of the previous cycles. The individualization usually depends on the clinical experience and the practice of the treating doctor, the published best evidence and the interpretation of the evidence available, and the patient characteristic and their expectations. And to reduce the cost, it's also the individualization will help you to reduce the cost and drop out of these patients with their physical and psychological burden. As I said, the individualization, you have to put it in mind that it is the anti-Mullerian hormone and intrafollicular count will help you in doing that. The stimulation protocol, this came for the last almost 5 years that you have to individualize. Before that, we were having almost fixed protocols to so many, but with the time now, from 2000, almost 17, 16, we start to individualize these patients, having not all, even sometimes the same patient. If she comes this time, I use one protocol, the next time I may change that protocol if it did not fit her. So we have to individualize your patients. Do we need to change? Yes, we need to change our fertility practice. Patients are getting married at an older age. We now have many technologies to help these patients. We should not continue doing same and the same again at what we used to do. The common mistake which would happen in the fertility clinic that we don't see the couple together. It's always on the burden of the woman. Husband semen analysis, believe me, sometimes we do see patients after so many years, fertility treatment without using semen analysis is not done for so many reasons. Investigation performs not once. For me, the fertility clinic, the patient should come only twice. First time, you take the history, do the investigation. Second time, review the investigation, make the plan. That's it. 2 visits. That's it. In 1 year, your patient should have full heart treatment. Either you make her pregnant or you send her to IVF. That's it. You don't need to, these patients should not stay in any fertility clinic more than 1 year. I get it. When the patient changed doctors, that's what happened. Usually the doctors insisting on repeating all the investigations. Why? I don't know. Okay, wasting the patient time and money, and doctors, they want to do something. They want to feel that we did something for that patient, even if it is unnecessary. Common mistake, we take them for surgery. Do myomectomy even if it's not needed. Do cystectomy even if it's not needed. Endometrioma is there, let us go and remove it and decrease further the ovarian reserve. Any unnecessary surgeries, sometimes it's done, and that all decrease their ovarian reserve, wasting time to go for IVF. The couple, that's what you should do. The couple must be seen together, treating as a unit, find the reason for the infertility, workup protocol should be there, and you should not waste time. Cost-effective laparoscopy, you don't need to do laparoscopy for all infertility patients. Why we need to do laparoscopy? You want to treat, imagine if you have a very busy schedule, for how many months that patient will wait to go for surgery? Unnecessary. Do HSG. HSG, what you need, HSG, you want to check their tubes, do the HSG. If the HSG giving you any doubt, then maybe you need to go for laparoscopy. Otherwise, send her for IVF. Okay, it sometimes depends even on the occlusion. Where is the tubal block? The testing should not stop when the problem is discovered. If you discover one problem, for example, if you discover that the patient had a tubal factor, don't stop there, because maybe she's having other factors. Look for the semen analysis. Maybe if they have other factors, so you can treat her in a proper way and you can advise her in a better way. A single abnormal result does not necessarily mean that the problem exists. Repeat sometimes. If you find an HSG with a proximal tubal block, maybe you need to repeat, or maybe you can take that patient for a laparoscopy or hysteroscopy. So and hysteroscopy with laparoscopy, if you find a proximal block, because the block which is at proximal, either because of the pain the patient had during the hysteroscopy, the HSG, or maybe she is having some uterine abnormalities, uterine polyp, for example, which is just at the level of the ostia. So there is no, if you take her for laparoscopy alone, you are not going to benefit her. You have to find out what is there in the cavity. After the workup, plan her action, and you tell her that you are coming now for this and this and that, so the patient will know when is her fertility treatment started and when it's going to stop, and what is her expectation. You need to progress from one part of the fertility treatment to more aggressive treatment. Don't waste time. If any fertility treatment, you remember the fecundity rate, which I told you in the beginning, it's 20 to 25% only. So that's it. If you treat a fertility patient, if she is going to conceive, she will conceive from the first 4 cycles, not more than that. If she did not conceive with that modality of treatment for 3 to 4 cycles, it's just a waste of time. Change your modality of treatment. Infertility treatment protocols and success rate are highly dependent on the ovarian age. That is the important thing you have to put. Associated risk factors increase with age, especially the endometriosis, as well as the other risk factors like chromosomal abnormalities. Diagnostics test after 1 year of infertility for women aged less than 35, without those listed criteria which I gave you before. 6 months for patients who are more the age of 35. Multiple techniques exist to assess ovulatory function, and several different types of protocols to treat female infertility. Most treatments have higher rates of success in younger patients. Elder patients, don't waste time, please. Common mistake which we usually do, that repeating fluid again and again without knowing what's going on, not monitoring ovulation and induction, and we don't know if they benefit from that or not. Delaying in treating infertile patients with endometriosis, tubal infertility, hydrosalpinx, please Don't go on treating them with ovulation induction after 3 to 4 times, knowing that the patient has to know that she has a risk also of ectopic pregnancy. Send them for IVF. Okay, even this tubal recanalization, these sort of things does not help. It's cleaning the tubes. Sometimes patient comes, clean my tubes, unless the tubal factor is showing obviously in the HSD that it is in a distal and maybe there is some flimsy adhesion. Maybe this patient will benefit, yes, from laparoscopy and incisiolysis. Otherwise, don't waste time. Don't repeat IOI again and again. More than 6 times, it's 6 times more than enough. If they ovulate, of course. Need to tailor the treatment according to patient age, medical diagnosis, and her budget. Go for IVF and don't waste time. Yes, IVF is expensive, I agree with you. But just because it is the right treatment is expensive or unavailable does not mean that you do the wrong treatment. Just because it is cheap, because sometimes you may harm your patient rather than giving them the benefit because of the wastage of time. Just because it's cheap does not mean that you are. Sometimes I do stop the treatment because you are just wasting their time. You have to tell them that this is the truth now. There's not much more I can afford you. Please go and find. And even sometimes we do change the patient among ourselves. Because if I cannot help that patient, let her go to another colleague who may help her, having more experience, having more techniques to help that patient. Don't keep her with you. IVF is, in fact, if that patient is has a treatment in private, if you check what money she spent in a private clinic doing the wrong medication, it will come to the budget of the IVF. Maybe sometimes the IVF is better for her. Give the good advice. Always remember there is no one size fits all in the fertility treatment, and we have to adapt the concept of individualization. Maybe sometimes vitamins do help these patients, and that's why we do sometimes give these patients some sort of vitamins to help them, like vitamin D, you have to put in mind, Q10, these sort of medications to help in the improving the quality of the eggs, but for a younger patient, not for the elder patient. And I think that's it. Thank you very much.